I was asked to talk about the pathogenesis of osteoarthritis, and I'm really delighted to do that today. So it's going to be a broad overview of this topic, and hopefully it will give you some ways of thinking about it that maybe you didn't have before in your toolbox. I have consulted over the last 24 months for a number of companies, but none of those have any relevance for this particular talk. So here's the OA elephant. We're all looking at this elephant, trying to figure out what it is, in fact. So today, what I'd like to do to introduce this OA elephant is to give you a quick overview of osteoarthritis, talk about the prevailing theories of the pathogenesis, and then at the end spend some time talking about some work that we've done looking at the innate repair ability of cartilage and try to think about how we might harness that to slow or prevent this disease. So as you're well aware, there are many phases of osteoarthritis. It's really a whole body disease, and it is extremely disabling. The prevalence increases, and actually this is a graphic of incidence. The incidence increases over age, and throughout the age, women are slightly more affected than men for all these various types of osteoarthritis. It's estimated that there are 302 million sufferers of osteoarthritis worldwide, and that the lifetime risk of symptomatic knee osteoarthritis is 40% in men and 47% in women, just slightly higher, and of course a little higher in individuals with obesity, both for load-bearing joints such as the knee and also for non-load-bearing joints such as the hand, suggesting that there's not just a load component for obesity, but an inflammatory component that is contributed by obesity. However, it's also been said that methodological issues, primarily the insensitivity of X-rays in particular, make it highly likely that the real burden of osteoarthritis has been underestimated. And I'm sure you you're well aware of this in the work that you do at HSS. This is a new graphic that came out last year describing the fact that the U.S. is the highest in the world in years lived with disability due to OA. So along the x-axis are the socio-demographic indices, and as you go to the right, you have the more rich countries, and then on the y-axis you have the age-standardized years lived with disability per 100,000 population. I had to really peruse this to try to find the United States, and here it is, way up here in this corner. Given the fact that we are so well off, this is really a kind of a shock. The Osteoarthritis Research Society has really worked hard to get the message out that osteoarthritis is a serious disease, particularly to regulatory agencies that are involved in approving drugs for OA, which we still do not have for remittive treatments. As you all know, symptoms play a very large role in the disease. Walking disability and physical inactivity is also very common, and it's been shown by Jillian Hawker that walking limitation explains about half of the association that hip and knee OA have with diabetes. And interestingly, there is not only increased morbidity, about half of all adults with heart disease or diabetes have arthritis, but there's increased mortality estimated to be increased by 55%. Most of that has been thought to be attributable to the walking disability, and this is one study that came out in 2019 showing individuals who were 45 years of age or older and looking at them relative to whether they had X-ray evidence or symptoms of osteoarthritis. This is the survival curve, and as this blue line shows you, for individuals without knee OA, either radiographic or symptomatic, you have this survival curve. But if you have knee symptoms, you have increased more risk of mortality. If you have radiographic changes in your knee, you have further increased risk of mortality. And then if you have both, you have the worst survival curve shown here. So this is a disease that's not just a discomfort, but also one that can kill you. And as Mary Goldring likes to say and has taught us all, osteoarthritis is a whole joint disease affecting all the tissues. So this is just a graphic of the normal and the abnormal, showing the various tissues, including the bone, the cartilage, the meniscus, the joint lining, etc., that are all involved in the disease. And I like to always remind people that cartilage has no blood or lymphatic vessels or nerves. So initially, the pain cannot come from cartilage. It just can come from collateral damage to other tissues due to the breakdown of cartilage. So it's really important for us to readjust our thinking to really start to try to work to detect the disease earlier, perhaps even before symptoms occur, like we do for heart disease with cholesterol, or with osteoporosis like we do for bone density, and treat it early to prevent that major disability that I showed you on that slide, because pain and imaging do not detect it early enough, probably. And the other thing it's worth saying is that we all believe that this early stage is much more likely to be amenable to treatment. So this is the broad overview of the pathogenesis of osteoarthritis. I thought that I would tell you about 6 different extant theories, and also to emphasize that it's no one theory that is correct. It's undoubtedly the fact that all of these interact to cause OA. Another funny thing about osteoarthritis is that because it can evolve from so many different types of etiologies, some people have likened it to a collection of orphan diseases. This is a very funny thing to think about when you talk about the most prevalent disease in the world, but it's due to the fact of the heterogeneity of presentations and etiologies of the disease. So the things that I'd like to touch on at a high level today are the theory of the evolutionary origins of the disease. That is, that there's a lag in skeletal development once we attained bipedalism. The second is a very important aspect, and that is the mechanical nature of the disease. The third is the inflammatory nature of the disease related to innate immunity in particular. The newly emerging evidence that then adverse microbiome plays a role in osteoarthritis pathogenesis, the role of increased cellular senescence in OA, and finally spend a little more time on the theory that we've had for a long time, which is that it's a homeostatic imbalance of catabolism and anabolism. And I'd like to tell you about our work looking at the ability of the joint to repair itself and how we might think about harnessing that for treatment. So the idea that osteoarthritis is an evolutionary disease is that once we attained bipedalism, a lot of the joints really were under different load and under different function, and this has led to osteoarthritis. Because we haven't had enough time during the evolutionary time to adapt to the changes in joint function. And we know that one of the oldest human types, Auroran, walked on 2 legs 6 million years ago. So in evolutionary time, I suppose that's a short period of time. This investigator, Martin Heusler, has been able to show evidence that, in fact, it looks like this hypothesis may be true for the low back. We're all very aware of osteoarthritis as a mechanical disease, and it's the Goldilocks principle. If the joint is underloaded, there is an adverse environment, and decreased protein synthesis and increased catabolic pathways are regulated in chondrocytes. However, if a certain threshold of strain is exceeded for a long enough period of time, catabolic events predominate. So this is the hyperloaded state. So there is some Goldilocks principle where you have just the right amount of load, which is physiologic and dynamic, that maintains matrix synthesis, decreases pro-inflammatory pathways, and increases anti-catabolic pathways. But it's important to point out that this Goldilocks principle might shift depending upon how much cartilage you have. So you may actually need to be underloaded if you don't have that much cartilage. So this might change in the context of the health of the joint. We've done a lot of work on the inflammatory component of osteoarthritis, and I just wanted to show you a few images from eterfolitide SPECT CT that we've done looking at the role of activated macrophages and neutrophils. The principle here is that the folate can bind to folate receptors, which are on and in abundance on activated macrophages, and as we've shown recently, activated neutrophils. There are on a few other cells, but most cells do not take up folic acid through the folate receptor or express it. So it's a very interesting way of both imaging these cells, as well as in cancer for targeting cells that have folate receptor with various reagents to kill them. So in this case, we're just looking at inflammation, and this is a knee where there are hot spots that we can see by nuclear imaging when we link the folate to technetium. And this is the hands of an individual that who has bilateral CMC osteoarthritis, and this is the sinogram of this knee where we can see the uptake. So when we looked at individuals, we looked at 25 individuals with knee osteoarthritis, evaluated both knees, and then we scored those blinded to their symptoms. We found that there were 26% of shoulders, 20% of the CMCs, 28% of fingers, 76% of knees, 12% of ankles, and 16% of MTPs that had increased uptake of the eterfolitide compound. Then we also looked at the symptom reporting of these individuals, and pain associations were strong for the uptake of eterfolitide and pain in the hands, the knee, and the ankle, which suggested to us, even though we had recruited on knee osteoarthritis, that these individuals have osteoarthritis of the whole body, and that pain is, one etiology of pain in osteoarthritis is the inflammatory component. So more recently, Ming-Fong Shui in the lab has looked at both the synovial fluid and the synovial tissue taken at the time of joint replacement and characterized the cell types. And we find three major cell types: macrophages, neutrophils, and T cells. And I must admit that the neutrophils came as somewhat of a surprise to me. So in the synovial fluid, they represented 26% of the cells, and in synovial tissue, only 8%. And it turns out that neutrophils don't express the alpha 4 beta 7 integrin, and so when they pass through the synovial tissue, they don't bind to VCAM, which is one way that it gets tethered in the cells by VCAM that's expressed by fibroblasts, whereas all of the other inflammatory cells do express this integrin. So it looks like neutrophils may pass on through the synovial tissue, so these might be just ones that are passing through, and they lodge in the synovial fluid. So we were wondering whether or not they were at all involved in the pathogenesis of osteoarthritis. So we characterized the intracellular cytokines and chemicals that these various cells made, and we found that synovial fluid elastase, which is only made by the neutrophils, was highly predictive of osteoarthritis progression by radiograph with an AUC of 0.78. Macrophages primarily were the source of TGF-beta, although there were several tissue sources. It was the predominant, and it also predicted the risk of radiographic knee-OA progression with a high AUC, 0.77. But the combination of those two were slightly more predictive, 0.83, which is a very high predictive score with really high confidence intervals. So it suggests to us that neutrophils do in fact play a pathogenic role in osteoarthritis along with other immune cells. We really didn't find much in the way of intracellular cytokines for the T cells, although they are there in abundance, and it would be really interesting to find out what role that they're playing. So this is a study that was published last year from our lab, and this was a single cell RNA analysis that was done by Jinhan Cho, and what he did was to isolate cells from the synovium and the cartilage from individuals who had undergone joint replacement. He collected the cartilage from regions that were macroscopically normal and ones that were near the lesions and the synovium of these same individuals, and characterized the cell types. And we found 7 major cell types in the cartilage and 12 major cell types in the synovium. So it's a really complex system. And then he asked a very interesting question, which is, given these cell types, what are the upstream activators of these? So those are these molecules that are listed here, predicted to actually create these cell phenotypes in the cartilage. And then he asked, where do they come from? Do they come from cartilage? Do they come from the synovial tissue? And do we find them in the synovial fluid? And so that's what this very complex graphic is, but it's really a tour de force. And if you're interested, I encourage you to go to the paper, because he spent several years working this out and showing that there are many cytokines that are in the osteoarthritic joints, and that as well as growth factors. And by and large, the cytokines, many of them are produced exclusively. 25 out of the 61 were exclusively expressed by the synovial cells, and the very large majority of the growth factors were produced by the chondrocytes. So it gives us a way of understanding the crosstalk of the joint and this whole idea of the joint as an organ and an interacting system. So I want to ask the question, why did it take us so long to recognize that osteoarthritis is an inflammatory disease? And it really gets back to what I said earlier. You don't have the normal mediators of inflammation. You don't have vessels, nerves, or lymphatics. And so the very first things that happen are you get the collagen fibril degradation and aggregate swelling and then loss. And then eventually these components are disease-associated molecular proteins that actually activate inflammation. So I think in part this is why it took us so long to really recognize this aspect of the disease. And then more recently, an adverse microbiome has been shown to be related to osteoarthritis. So shown here is a study that just recently came out by Zheyu Wang, who did a very interesting study where he raised germ-free mice and he orally gavaged them with human microbiome, either from people who did not have osteoarthritis or individuals who did have osteoarthritis, and individuals who did not have metabolic syndrome or who did have metabolic syndrome. And these animals were treated with a meniscal ligamentous injury. So for animals that were germ-free who had a the injury, they had an ORSI score of 4.8. Whereas animals that were raised in a specific pathogen-free environment but not germ-free, they had a higher ORSI score. So it suggests there may be some pathogens involved. But for individuals who had the human microbiome, whether or not it was OA an individual or not, they had even a slightly higher ORSI score. But the individuals who had the microbiome from humans with OA and metabolic syndrome, they had the even highest score. So we hypothesize that these individuals have the most adverse microbiome, and this is the first direct evidence of the microbiome actually exacerbating osteoarthritis. So altogether, this supports the 2-hit model of osteoarthritis pathogenesis, as we call it, which means one hit is provided by the adverse gut microbiome, but that may not be enough in and of itself, and it activates innate immunity, and the other hit is underlying joint damage. So you have this weakness that is taken advantage of by the adverse inflammatory microenvironment from the microbiome. Then cellular senescence is another theory that relates to this disease, which is gaining prominence as more and more people are realizing that if you look at joint tissues, you can find the sine qua non factors that characterize a senescent cell: increased P16, increased senescence beta-gal activity, and activated DNA damage response. So this was a study that was done by using UBX0101, which is a senolytic, which kills cells, organcyclovir, and they showed that in mice, they could kill senescent cells in cartilage, and this protected them from OA. So this and other drugs have been looked at as a mechanism for dealing with osteoarthritis, and the idea being because these cells make inflammatory cytokines, that even by getting rid of them, you're better off than by having them, because they're causing this paracrine injury to other cells. Probably one of the theories that's been around with us for the very longest is that osteoarthritis is an imbalance of joint tissue homeostasis. That is, that you have an imbalance in degradation and synthesis, and the synthesis is inadequate to be keeping up with the amount of degradation that goes on. And so when you have high degradation or low synthesis, then the idea is that joint tissue degeneration can occur, and you can see radiographic osteoarthritis progression. One of the primary biomarkers of degradation that we've had around for a long time is urinary CTX2. And we find in this study, which is a section from a human knee, from an OA knee, we find that CTX2 can be identified in the calcified cartilage as well as in the surface fibrillated cartilage. And we also find it in osteophyte. And so it has been very prominent, and I'll talk about it a little bit further, as far as an osteoarthritis marker. We also now have an increasing understanding that low synthesis is also related to osteoarthritis. And what's really wonderful about these types of markers is that they all come from the same molecule, type 2 collagen, which is specific to articular cartilage. So here is a schematic of a type 2 collagen molecule, a triple helix, a homotrimer. And what happens is that when it's synthesized, these prodomains at the ends of the molecule are synthesized, and these prodomains contain the so-called P2AMP and P2BMP, or ProC2 epitopes. So when these epitopes are found in the bloodstream, they are reflecting synthesis of type 2 collagen. With the maturation of type 2 collagen, those are cleaved, and then that leaves the core triple helix. And CTX2 is at the C-terminal end of this. And so you can see it here. And then with further degradation of cartilage, or this molecule, that molecule is cleaved, degraded, and it's lost. So it's cleaved here, and that causes this to be lost. So when this is identified in the urine, it's reflecting degradation of type 2 collagen. So from the same molecule, we have both synthesis and degradation markers. And so this allows us to look at both processes simultaneously in the context of OA. And what we had shown before is that CTX2 in the urine is a really good whole body measure of the burden of osteoarthritis. So this was a cohort of individuals who had hand, hip, knee, and spine x-rays, and they were scored in exquisite detail, looking at the number of faces with osteophyte across the body and the number of faces with joint space narrowing. And as you can see, it's a remarkable correlation of CTX2 with osteophyte burden and cartilage loss. And so typically, we have not been utilizing these systemic biomarkers for looking at whole body burden, but we really should be, because what we've typically tried to do is to see how well do they report on local disease. But as I showed you, when we had recruited people with local disease, we find they have disease in lots of other places as well. So eventually, we'll be utilizing these to look at whole body burden and the effects of treatments on whole body burden of disease, and I think that will be an exciting turning point. So just to show you, these are data about CTX2. This is the FNIH study that showed that for individuals who have pain and radiographic worsening over the context of 4 years, they have an increased odds ratio predicted by CTX2 for this progression, and CTX2 was better than any of these other biomarkers. That these are all the most common ones we use in the field. It was better than all the others in terms of predicting osteoarthritis progression. So the idea being that the progressors have the high level and the non-progressors have the low level. And that this actually difference can tell you who is on a trajectory of progression. CTX2 has also now more recently been shown to predict the risk for total joint replacement. So these are people who had CTX2 measured in the urine. Either they were in the highest quartile, which is this red bar, or they were in the lowest quartile of CTX2. And those who were in the highest quartile underwent joint replacement at a higher rate. This is percent free of total joint replacement, so higher rate of total joint replacement in the people who had the highest quartile of CTX2. So the idea is it's predicting what the FDA would consider clinically relevant outcomes. Baseline CTX2 was predicted 3 times higher risk of total joint replacement or a 9 times higher risk of total knee replacement. Similarly, P2AMP, which is the other side of that coin, when it is low, that would mark the progressors, and the non-progressors would have a high rate of type 2 collagen synthesis, and that's exactly what we saw in the FNIH study. The baseline, and in this case, the time integrated concentration, which is the average of the baseline in the 12-month P2AMP, predicted, if it was high, it predicted a lower rate of pain and radiographic worsening over the course of 4 years. Genetic studies have told us now recently that, in fact, the synthesis component in OA is very important. So far, now about 90 risk alleles have been identified for osteoarthritis, and interestingly, many of them are growth factors, and so those are shown here. This is a paper by Louise Renard, and she spoke at ORSI in 2019, last time we had an ORSI in person. And interestingly, a number of these are from the TGF-beta superfamily. So it tells us that growth factors are extremely important in this disease. And the data so far for GDF5, which is the one that's the most well characterized, showed that a 10% decrease in the transcription of GDF5 over the course of many years increases your risk. So maybe just a small amount of decreased growth factor response in the context of a normal wear and tear use over the course of a lifetime is enough to distinguish you as a somebody who then suffers from osteoarthritis compared to somebody who does not. So to put it all together, Tanya Vincent and I had a wonderful opportunity to write the chapter on osteoarthritis for the Goldman Cecil textbook of medicine. So for this big honor, we thought, well, let's put together put our heads together, and over the course of a year, we tried to integrate the world of mechanics and the world of inflammation, which are represented by the two of us. And as Suzanne and I were talking about before, it's really important not to be siloed in one or the other. And so we worked hard to try to understand each other and try to put this together. And so I have found this to be a very useful construct for thinking about osteoarthritis pathogenesis. And the idea being that mechanical load is absolutely essential for cartilage health. But in the context of either thinning or thickening, you can get an injurious load in that context. And injury itself can cause a change in the load pattern. So joint cells perceive that injurious load. They try to clean up that load, and they produce proteases and cytokines. But unfortunately, these are the ancient signals to the body that there's damage and that it has to be cleaned further. And there's also a cell senescence response, as I told you before. And this causes more macrophages, which are the type A cells, as opposed to the fibroblasts, the type B cells, to be recruited, increases synovial inflammation that potentiates the catabolic damage, that weakens the cartilage further, that then makes whatever load you did have now even more injurious. And so you end up having this negative cycle. But what we have been looking at is that there is actually an endogenous repair cycle. And that's the last thing that I want to spend some time on and tell you about, and try to think about how we could harness this to fight this while we turn this off, maybe turn this on to actually do joint repair, not just stopping the disease. So what do we know about cartilage regeneration in humans? It's generally believed that the articular cartilage has very little intrinsic repair capacity, with collagen half-lives estimated to be between 200 and 400 years. So your collagen lives longer than you do. By carbon-14 bomb pulse method, Heinemeyer showed or published that collagen formation and renewal is very limited in adults. So the way this was done was that in the 1950s and 60s, so many nuclear bombs were tested that half of the atmosphere, that there was a huge increase in the atmosphere in C14 content. C14 is has a half-life of 5,630 years, but in fact, because it gets dissipated into the ocean, it effectively has a half-life of about 11 years. It gets into the food chain, people eat it, and then essentially we label our tissues with C14. And so by taking advantage of this natural pulse chase experiment, she concluded that after adolescence, there's virtually no further collagen turnover or renewal. But we know that in the context of osteoarthritis, that there is an increase in cell activity, there's an increase in protein synthesis, and cartilage appears to grow after knee joint distraction. So all of these things suggest that there is some ability for cartilage to repair itself. So we were trying to understand why we have this disconnect in these pieces of information. Before I tell you about that, I just want to introduce a little bit about limb regeneration. We just had an NIH conference for the last 2 days about limb regeneration, which was extremely fascinating. And as you're undoubtedly well aware, there are some animals that can regenerate a complete limb after amputation, and it all occurs by a bud of cells called the blastema, which appear within a week of the injury. And these cells are dedifferentiated from a number of different tissues, and then they redifferentiate to form the limb. And it turns out that humans, even at a young age, are able to replace and regenerate distal digit tips. And but with age, that characteristic wanes, and so we saw a lot of graphic depictions of this in the last couple of days. And so wouldn't it be great if we could harness whatever that was that humans did have or do have at a young age? This really interesting experiment was done and published in 2016, where they took 3 different animals that diverged in evolution 420 million years ago, and they hypothesized that if they could figure out what was common to limb regeneration across these animals, they would know what the master regulators of limb regeneration would be. And they found that there are a group of microRNAs that are common to all 3 of these organisms. So taking this information, we wondered, could any of these microRNAs promote human tissue regeneration? And do we actually express any of these? So we analyzed 3 of the top ones, MIR21, MIR31, and 181C. And what we found, in fact, was that they're very high in the ankle, they're intermediate in knee cartilage, and they're low in hip cartilage. And so then we wondered, do they relate to new protein synthesis or regeneration of cartilage? And to do that experiment, we developed a method of mass spec that looks at protein and natural protein aging. And so that's introduced here. Normally, when a protein has an asparagine or a glutamine, over time, it deamidates to form aspartate and glutamate. And by doing mass spectrometry, we can measure peptides and see ones that contain asparagine or glutamine, and then we can look to see, are there any aspartate or glutamate forms of this, and how much are there relative to the native form. And the amount of deamidation that occurs in any particular spot is dependent upon the 2D and the 3D structure, the temperature, and the pH of this. But once you know that, it acts like a clock. It deamidates at like a biological clock. Each one of these spots is a different clock, but it's a clock in and of itself. And so we isolated cartilage, we did mass spec, and the idea being that if you have a high deamidation to native peptide ratio, then you have very low protein turnover, because the deamidated forms are the old ones. They've been around a long time, long enough to be deamidated, and we see that. That's the characteristic of hip cartilage. When you have a low deamidated to native form of the peptide, that is a high turnover state, and that is what we see for the ankle for multiple proteins. We were able to actually, because we were able to predict the 3D structure of aggrecan and determine the deamidation rate constant, we were able to estimate the half-life of turnover of aggrecan, and it's 1.8 months in the ankle, and it's 3.8 months in the hip. So it turns over much more slowly in the hip, in the ankle, this aggrecan G1 domain. And for collagen, it's very interesting. We did find that type 2 collagen does turn over, and it has a 3.9 year half-life in the ankle and an 8.6 year half-life in the hip. And I should say that what we're looking at is soluble collagen, not collagen that is insoluble, which is what Heinemeyer studied. She talked about all collagen, but in fact, she looked at the insoluble component that you get after guanidine HCl. So most people are familiar with the fact that microRNA are repressors. So we wondered, how could a repressor actually be increasing collagen synthesis? And we found that microRNA 21 increased all of these collagens, the synthesis of all of these collagens. And so we were able to map the intermediate TGFBR2, which is a repressor of collagens. MicroRNA turns off TGFBR2, which then releases the repression on collagen. So it looks like there are these intermediate proteins that are impacted by the microRNA that are regenerative. So putting it all together, I like to think about a house. So when I think about a house, I think about forming a foundation, which I would liken to the calcified cartilage. And then we build the framework on top of this foundation, and I would liken that to the insoluble collagen component. It's acid insoluble, it's guanidine HCl insoluble, and acid soluble. This has very little or no turnover. You're not going to change that. You're born with that, you live with that. After adolescence, that's unchanging. But then on top of that, you put the roof, the windows, the siding, the furniture, the rugs. Those are the soluble collagen components and the non-collagenous proteins, and they all can turn over. You can change your furniture and your draperies. And so we find that you can change your furniture and your draperies in the ankle, but not so well in the hip. So I think this has some treatment implications. When we think about this, we think about there being a little salamander in all of us with this orchestrated reparative process. And the idea being that because the ankle can regenerate at a high level, perhaps we only need to block the breakdown when we have an injury. But block the breakdown, but after an injury, we may also need to boost the repair because there might be such a major injury. But under normal circumstances, we may not need ever to have a pro-anabolic for the ankle. Whereas for the knee and especially the hip, we might actually need to block the breakdown, but also boost repair in order to really salvage this joint. And the final slide I just wanted to share with you was a new study that I was really fascinated by, which made me wonder, is there a maladaptive repair response that needs to be blocked? So this paper was telling us that the antidepressants that are in the serotonin reuptake inhibitor class protect OA in mice. They're known to be anti-inflammatory, and an original study on fluoxetine, which I think is Prozac, gave weekly intra-articular injections into rats with destabilized medial meniscus, and they showed that it slowed osteoarthritis. And this was postulated to be due to inhibiting the Wnt beta-catenin pathway. And then the more recent one that we just heard of last week was paroxetine, which I think might be Paxil. And they're proposing that it inhibits a G protein-coupled receptor, GRK2, and that thereby inhibits hypertrophic chondrocyte development and OA progression and increases matrix regeneration in mouse DMM model. But I also found a literature that showed that GRK2 impairs canonical Wnt signaling, and they showed that it's elevated in injured and osteoarthritis cartilage. So it might be that this all devolves back to the Wnt pathway, but it also may be related to a maladaptive repair response, and we might need to have to block that, which is these hypertrophic chondrocytes. And so it really made me wonder, do we have a treatment that's been hiding in plain sight? Here they showed their DMM and vehicle treated animals, loss of safran and O at the surface and much decreased cartilage thickness. And these were the animals that were treated with the SSRI. So this is a tantalizing piece of information. Much more work needs to be done in humans to really determine what the benefit. So putting it all together, osteoarthritis is a disorder involving movable joints characterized by cell stress and extracellular matrix degradation, initiated by micro and macro injury that activates maladaptive repair responses, including pro-inflammatory pathways of innate immunity. The disease manifests first as a molecular derangement, abnormal joint tissue metabolism, followed by anatomic and/or physiologic derangements, characterized by cartilage degradation, bone remodeling, osteophyte formation, joint inflammation, and loss of normal joint function that can culminate in illness, meaning the symptoms of the disease. This definition is on the ORSI website, and anyone is welcome to contribute to it. It's a moving definition, and we started this a few years ago, realizing that for many societies who are disease related, focusing on a particular disease, they essentially own the definition of their process. So we thought it was important to come up with the definition and make it accessible to the members of the society and the field to keep this up to date and to really develop an understanding of the pathogenesis. I just want to acknowledge my coworkers that have contributed to this, my wonderful lab members, my funding that I've had for much of this work, and just point out that were I to be given a third wish, first, second, or third wish, to be honest, I would follow this advice, that is, using it to cure osteoarthritis.